Good morning, everyone. Welcome to our final day of the 2026 AAES meeting. Our final scientific session will begin. We will have our final breakout session upstairs at 9, Pearls Logistics and Best Practices for Adrenalectomy Perioperative Care. May I ask our president to come on stage?
Good morning, everybody, and thank you for being here on time. Hope you had a good time last night. I'd like to welcome to the stage my co-moderator, Dr. Lisa Reed, who's from Cooper University in New Jersey. And together we'll discuss 6 papers on this session. I'd like to call to the stage our first paper. The presenter is Raj Roy, and this is entitled Hazards of Delay. Should early parathyroidectomy be the standard for secondary hyperparathyroidism of renal origin? And it is from the group at UAB. Thank you, Dr. Roy.
Thank you all for the opportunity to present. One of our authors is NIH funded. Secondary hyperparathyroidism develops in nearly all patients with advanced chronic kidney disease, and a variety of target thresholds for PTH has been studied in this population to optimize both bone and cardiovascular outcomes. Particularly, the DOPS study in 2020 identified PTH of greater than 600 as associated with higher cardiovascular mortality and hospitalization in patients on chronic hemodialysis. KDIGO and AAS guidelines recommend PTH below 9x the upper limit of normal as well. Parathyroidectomy remains the definitive treatment for severe kidney-related secondary hyperparathyroidism beyond these thresholds. However, the era of calcium mimetics has introduced delays of up to 2 years despite elevated PTH levels. Although guidelines recommend parathyroidectomy before kidney transplant, there's a lack of consensus on optimal timing in this population. With that background, our hypothesis was that delaying parathyroidectomy in patients with secondary hyperparathyroidism and very high PTH despite medical management is associated with worse clinical outcomes. To investigate that, our primary objective was to evaluate whether delayed parathyroidectomy is associated with higher risks of symptomatic, skeletal, metabolic, and cardiovascular outcomes compared to early surgery. Our secondary objective was to assess whether timing of parathyroidectomy relative to kidney transplant before versus after influences kidney graft failure and other adverse outcomes. For our methods, we use the Trinidx Research Network to identify adults with PTH of 600 or greater and CKD stage 5 or GFR of 15 or below. We excluded patients with prior kidney transplant. Exposure groups were defined as early parathyroidectomy, that is surgery within 2 years of index PTH elevation, and delayed parathyroidectomy, that is surgery beyond 2 years. Outcomes of interest were malaise and fatigue, osteoporosis, renal osteodystrophy, and cardiovascular events. Patients were propensity score matched 1-to-1 on demographics, Charlson scores, BMI, labs, dialysis dependence, and calcium mimetic and bisphosphonate use at index PTH elevation. The index event was defined as the first instance of PTH of 600 or greater. Turning to our results, for the primary analysis, we identified 60,000 patients with PTH of greater than 600 and CKD stage 5. Excluding kidney transplant, we had about 57,000 patients, of which 2.4% underwent parathyroidectomy. 916 patients underwent parathyroidectomy within 2 years versus 497 after. Table 1 shows our demographic characteristics before and after propensity score matching. After matching, we had about 365 patients in each group. The groups were well balanced across most covariates. We also matched for Charlson scores, dialysis, and calcium mimetic or bisphosphonate use that is not shown here. Of note, PTH was not included as a propensity score matching variable as it is a part of cohort definition. Our primary analysis comparing delayed versus early parathyroidectomy demonstrated that delayed parathyroidectomy was associated with significantly higher risks across multiple outcomes, notably malaise and fatigue, osteoporosis, hypercalcemia, and renal osteodystrophy, all showed significantly elevated crude risks. On performing time to event analysis to account for differential follow-up, malaise and fatigue, osteoporosis, and hypercalcemia remain significantly elevated. Looking at cardiovascular outcomes, delayed parathyroidectomy was associated with significantly increased crude risks of heart failure, ischemic heart disease, acute MI, and atrial fibrillation. Hazards did not achieve significance here. For our secondary analysis, in those who underwent transplant, 620 patients had a parathyroidectomy before kidney transplant versus 1,158 after. Median follow-up was more or less similar between the groups at around 8 years. Among the matched cohort of 528 patients per group, parathyroidectomy performed after transplant was associated with 2.5 times higher hazards of developing graft failure. Hypercalcemia and malaise were also significantly elevated in the post-transplant surgery group. Osteoporosis and cardiovascular outcomes did not show any meaningful difference here. In conclusion, delaying a definitive surgery beyond 2 years of meeting PTH thresholds is associated with higher hazards of osteoporosis, malaise, fatigue, and hypercalcemia. Additionally, timing relative to kidney transplant is clinically meaningful, with parathyroidectomy performed after transplant associated with substantially higher risks of graft failure. Thank you for your attention, and I'm happy to take any questions.
Thank you, Dr. Roy. This interesting paper is now open for discussion. I think I see someone walking to the mic. Nope. Quick left turn. While everybody's coming up, I do have a question for you. So it seems like your central message is that the longer you wait with untreated disease and in some ways until transplant, that you suffer an increased cardiac risk in particular. When you look at your study size and the way those patients are matched, how confident can you be in that conclusion, since you weren't matching directly for cardiac comorbidities?
Well, definitely what we did was we tried to be more rigorous with the matching, the propensity score match, especially because with large data sets, we have to be careful because there might be confounding variables. What we used specifically was we referenced this methodology where we tried to be more aware of the biases that come with patient selection for surgery. We tried to match for each and every sort of surrogate ICD codes for the Charleston comorbidities. The caveat here, of course, is that this patient, if you look at the mean age, was a younger population, and they were most likely surgical candidates. But with that in mind, I think we did a pretty good job of matching for most of the comorbidities.
Thank you for the explanation. We'll go to the central mic, please.
Sarah Altman, UT Southwestern, no conflicts. This is great work. Have you had much luck socializing this with your nephrologists? And have you noticed any changes in the referral patterns in your local area?
Well, something that we're prospectively studying definitely is trying to build these relationships. We have good relationships with our nephrologists and our transplant team. But we are also sort of taking the study forward and prospectively studying some of the things like the malaise and fatigue. For example, we are prospectively studying that. In terms of getting more referrals or building those connections, we're still working on that, but we have had good sort of response, having the data to sort of relay that information.
Time for two more quick questions. We'll go to this mic and then...
Saif al-Subhi from Saudi Arabia. Thank you for the nice presentation. I want to ask you about the type of parathyroidectomy for both group. Like before kidney transplant, you do total, and after transplant, you do like it is tertiary, you will do a focused parathyroidectomy, or it's the same procedure?
Well, definitely we take that with a more case-by-case basis. For example, if the patient was a young patient and we did not want to sort of render them hypoparathyroid, we would be aware of the fact that we would prefer a subtotal parathyroidectomy in those patients versus if in an older sort of patient, we might prefer a total with an auto transplant.
So do you think this will reflect in your result because after kidney transplant, you are not doing total parathyroidectomy, so still you have high rate of recurrent hyperparathyroidism?
Unfortunately, in this study, we were not able to sort of separate or make a distinction between the type of parathyroidectomy, but that is definitely a great direction I think we can work on and take that forward.
Thank you.
Thank you.
Dr. Roy. And Dr. Reed will introduce the next paper.
So our next paper is from the group at Mount Sinai, being presented by Dr. Cost, Effect of a Multidisciplinary Renal Hyperparathyroidism Conference on Surgical Management and Outcomes.
Good morning. Okay. My name is Maureen Cost. I am a current resident at Mount Sinai Hospital, and today I'll be presenting on behalf of Dr. Shaw, who's our current fellow, and unfortunately could not be here today. We have no disclosures. Renal hyperparathyroidism is a disease that requires nuanced, individualized management. Over the past 2 decades, parathyroidectomy rates have declined nearly 50% nationally, largely driven by the introduction of calcimimetics and the relaxation of PTH targets. But this shift has also introduced a new challenge. Patients are frequently managed in silos by nephrology, endocrinology, and surgery, without a shared framework for deciding when surgery is truly the right answer. AES guidelines call for interdisciplinary communication, but no structured evidence-based model has been described. So that is the gap that we aim to fill. In September 2022, we launched a bi-monthly renal hyperparathyroidism conference at Mount Sinai. Each case is reviewed jointly by nephrology, transplant nephrology, endocrinology, and endocrine surgery. And we examine PTH trends, calcium, phosphorus, dialysis status, transplant history, and clinical sequelae. And we arrive at a consensus decision, either to optimize medical therapy or to proceed with parathyroidectomy. Our hypothesis was that this team-based approach would improve medical therapy utilization and refine surgical selection. So we conducted a single-center cohort study comparing 2 groups, a historical control with 41 patients seen between January 2021 and December 2022, who were evaluated by endocrine surgery alone, with surgical recommendations made at the surgeon's individual discretion. And then we had a program cohort with 85 patients who were seen at our multidisciplinary conference between September 2022 and September 2025, with recommendations made by consensus. And our primary outcome was recommendation for parathyroidectomy. We found no significant differences in age, sex, renal hyperparathyroidism subtype, duration of dialysis, or baseline calcium, phosphate, PTH, or calcimimetic use between the 2 groups. However, we found a much lower surgical recommendation and utilization rate in the program group. In the control group, 90% of patients were recommended for surgery, and 83% ultimately endured parathyroidectomy. In the program cohorts, those rates dropped to 49% and 36% respectively, which were both statistically significantly different. On multivariable logistic regression, adjusting for demographics, biochemistry, and renal hyperparathyroidism subtype, we found that participation in the multidisciplinary program was independently associated with a reduction in the odds of being recommended for surgery. Higher baseline calcium, higher PTH, and calcimimetic use were also significant predictors for surgery. So we also found that reducing surgical utilization did not come at a cost. Among patients with at least 6 months follow-up, biochemical treatment failure rates were virtually identical at 39.4% in the control group versus 39.7% in the program group. And on multivariable analysis, surgery remained independently protective against failure when it was performed, with an odds ratio of 0.018. In other words, the program appears to be selecting the right patients for surgery. Longitudinally, both groups also showed significant improvements in calcium, phosphorus, and PTH over time. There was no significant group by time interaction for any of the 3. So there were equivalent biochemical control through a strategy that used substantially less surgery. So in conclusion, a structured multidisciplinary renal hypoparathyroidism conference significantly reduced surgical recommendation and parathyroidectomy rates without any compromise in biochemical outcomes. So surgery, when appropriately selected, remained effective. This work suggests that team-based individualized case review is a scalable model for optimizing patient selection in renal hypoparathyroidism. Thank you.
This paper is open for questions. Dr. Du.
Quang Du from San Francisco. This paper and the previous paper are both very, very interesting, but in my mind, it seemed to tell me different things. The people from UAB tells me that I should do more operation and earlier, and your paper tells me that I can do fewer operations for renal hyperparathyroidism. Can you reconcile that for me?
Yeah, thank you for your question. I think something we have to look at here is also the PTH levels of our patients preoperatively, which is not something that we have included, unfortunately, in this study. So if we are able to stratify our patients by PTH levels, we may find that the patients with higher PTH levels should potentially have surgery earlier and be able to reconcile both of the studies.
Abby Fingerett, University of Nebraska, no disclosures. Thank you very much for an excellent study, well presented. I will complement Dr. Du's question with a follow-up, which is you showed no biochemical differences, but what about transplant outcomes? Did you follow any of these patients forward to transplant? And if so, did you note a difference in that patient population? Thank you.
Yes, thank you for your question. Multiple patients ended up going to transplant surgery after 6 people in the control group compared to 14 people in the program group, and no patient had any graft failures or any bad outcomes as of now.
Go back over here.
Scott Wilhelm from Cleveland, Ohio. Very nicely presented study. This is always a very challenging group of patients to work with in terms of their adherence to medications and anybody with this kind of level of chronic disease in the renal failure population. So were you guys able to extrapolate? Do you think any of your outcomes were related to the fact that you now have a group of patients being actively studied in a team-based approach, that they actually did better taking their cinacalcet, better with other medical management of their phosphorus levels that led to patients not needing as much surgery? Could you tease any of that out?
Thank you for your question. It is possible. A lot of these patients were actually referred by outpatient nephrologists, and the follow-up care was often continued by those nephrologists who may not have been at that conference at the moment. But that is a good question. We keep track of the patients, but it is difficult to know exactly what kind of medications they're getting at dialysis and through their outpatient nephrologist, but that is a good question to study for us in the future. Thank you.
Thank you.
Thank you.
Thank you.
For our third paper this session, I'd like to welcome Eddie Linchango to the stage, who will present Extent of Surgery and Survival in Localized Oncocytic Thyroid Carcinoma, Total Thyroidectomy versus Lobectomy. And this is a multi-center study, including sites such as UCF, University of Kentucky, the NIH, Duke University, University of Miami, and also UCSF. Thank you.
Thank you for the great introduction. Actually, this is a SEER database study, so those are the institutions from our authors. I have no disclosures. Oncocytic thyroid carcinoma accounts for approximately 3% of all differentiated thyroid cancer and is distinguished by higher rates of local regional recurrence and a reduced response to radioactive iodine therapy. These characteristics have contributed to the long-standing preference for total thyroidectomy. However, the ideal extent of surgery in the literature remains unclear. Therefore, our study aimed to compare patients with localized oncocytic thyroid carcinoma who underwent total thyroidectomy and lobectomy for overall survival and disease-specific survival. The SEER database was used from 2000 to 2022 And our inclusion criteria were patients older than 18 with localized oncocytic thyroid carcinoma as defined by the SEER summary stage, as minimal to no extrathyroidal extension with no evidence of lymph node involvement, or in other words, low-risk thyroid cancer. Patients underwent total thyroidectomy or lobectomy, and importantly, those who underwent lobectomy and had documented radioactive iodine therapy use were presumed to have undergone completion thyroidectomy and therefore were reclassified as total thyroidectomy. In order to test this variable, two sensitivity analyses were performed, first using the SEER surgical codes only, and second, the period of diagnosis. Additionally, we use Kaplan-Meier methods and a multivariable Cox regression to test our primary outcomes, 5-year and 10-year overall survival and disease-specific survival. Overall, 3,667 patients were included. The median age was 58 years, with 25% of the cohort being older than 70. Most of the patients were female and white. And in terms of the surgical extent, 83% of the patients underwent total thyroidectomy and 17% underwent lobectomy. 64% of the patients had radioactive iodine therapy after total thyroidectomy, and the median follow-up was 92 months. When evaluating the impact of surgical extent, there were no differences in 5-year and 10-year overall survival and disease-specific survival for patients who underwent total thyroidectomy versus lobectomy. The sensitivity analysis shows similar results. For the radioactive iodine status, those patients who did receive therapy had a higher rate of overall survival at 5 and 10 years. However, there were no differences in disease-specific survival. When stratified by tumor size, there were no differences at 5-year overall survival for tumor smaller than 4 centimeters. However, those patients who underwent total thyroidectomy for tumors larger than 4 centimeters, they had a higher rate of overall survival at 5 years when compared to those who underwent lobectomy. Importantly to notice, the sensitivity analysis didn't show any differences in overall survival for either size. The multivariable Cox regression analysis, including age, sex, surgical extent, radioactive iodine therapy, and tumor size, demonstrated that only age remained the independent factor predicting overall survival. Our study had several limitations. First of all, the SEER database doesn't capture several factors which may influence prognosis, including molecular testing, thyroglobulin, and recurrence. Second, misclassification bias may persist despite our reclassification strategy and sensitivity analysis. And third, the limited number of events precluded additional analysis of disease-specific survival. Nevertheless, our study expanded on prior work through a larger sample size, longer follow-up, sensitivity, and subgroup analysis. In summary, this SEER analysis suggests that maybe lobectomy is a reasonable approach for patients with localized oncocytic thyroid carcinoma with tumors smaller than 4 centimeters. Thank you. I'm happy to take any questions.
This interesting paper is now open for discussion. We'll start with Dr. Ashok Shaha.
Shaha, New York. Thank you very much. It's a huge data, so we can't challenge the data. But we do recognize that in the thyroid literature, there are approximately 800 SEER papers on thyroid, out of which approximately 400 are from China. It is a public domain, so I think it is very easy to write the papers. But we need to interpret that very critically. The most important prognostic factor in oncocytic carcinoma is minimally invasive or widely invasive. And that information is not provided in your paper. The other issue is, what was the story with the opposite lobe? Was there any nodule? Because if there was a nodule, we know total thyroidectomy is indicated. So without this information, it is a little difficult to interpret the entire paper. And I think the last most important is, we decided somewhere around 2015 when the guidelines came, we're not going to debate in AAES about lobectomy versus total thyroidectomy. I think we made that executive decision. But what is important is we have never put in the equation the quality of life of these patients. I'm convinced beyond any doubt that the lobectomy patients do much better compared to total thyroidectomy. And if the patient had a lobectomy, no matter what the final pathology report is, unless there is a major vascular invasion or gross extrathyroidal extension, we are very comfortable with lobectomy alone to maintain the best quality. Thank you for a great presentation.
Thank you.
Thank you for the question. Any comments back to Dr. Shah? Or?
Well, yeah, we acknowledge that, we are not able to analyze minimal invasiveness in the database, but they definitely separate the patients in the C database as localized and widely invasive. They don't provide the specific variables as how they did this differentiation. So we relied on the specific researchers that they were extracting the data. And definitely quality of life is very important, to take into consideration in this kind of cancers. It's like a PTC that, quality of life is very important to decide whether lobectomy and total thyroidectomy would be the appropriate approach. So for our future study, probably we're gonna try to include quality of life and probably do a multi-center study with more granular data.
Thank you. And I don't see anyone else at the microphone, so I'll take the prerogative to ask you another question. You mentioned exposure to radioiodine as a variable. It's not clear to me whether those patients had scans or if they all had treatment, since it's applied fairly selectively in the oncocytic population. So if you could comment on that, and as relates to that overall treatment strategy that Dr. Shah explained, this paper reminds me a little bit of the controversy around the original Villamoria paper about the advantage of total thyroidectomy, where there was a signal that patients in the lobectomy group may have been guided toward lobectomy because either they had larger, more difficult to resect tumors that caused surgeons to back off, or that they had significant comorbidities, elevated surgical risk. Do you think this study could suffer from those same concerns?
Yes. For the second question, the C database doesn't capture comorbidities, so it's very hard to tell if these factors contributed to the decision of the surgeon to whether go for lobectomy or total thyroidectomy. But definitely in our table number 1, we saw a higher rate of patients older than 70 undergoing lobectomy. So probably it's because age comorbidity related. And for the first question, which was
just whether those patients radioiodine were scanned or treated.
Yeah, so per the SEER summary stage, they have the definition of the radioactive iodine therapy variable, and they mentioned that it's actually the therapy rather than the imaging.
Thank you. And then I think we'll close this paper with a question from Dr. Parangi.
Surya Parangi, Boston. Great paper. I just have 2 quick questions. One I missed, was there any signal from being male?
Yeah, the univariate analysis showed that male patients had a higher, lower rate of overall survival, but the multivariable analysis didn't continue with that significant.
And was there any way to sort out, now with sort of the concept of Hürthle cell, oncocytic carcinomas are not that responsive to radioiodine, and the endocrinologist not wanting to even give radioiodine in many cases. Was there any signal on that from your data, whether there was or was not a response?
That's a very interesting question, and due to the limitations of the C database, it's very hard to tell the response of treatment. That's why we used the classification, the reclassification variable, but we couldn't answer that question with our study. For further studies, we can do that.
Thank you.
Thank you, Dr.
Very nice. Our next paper is from the University of Michigan Hospitals, being presented by Dr. Shi. Surgeon acceptability of an intervention to promote use of thyroid lobectomy for small, low-risk thyroid cancer.
Good morning, everyone, and thank you so much for this privilege. This work was funded by a R37 grant from the National Cancer Institute of the National Institute of Health. The content we're presenting today is solely the responsibility of the authors and does not represent the views of any of the organizations. Although guidelines continue to emphasize the de-escalation of total thyroidectomies for low-risk thyroid cancers, clinical adoption has lagged due to several patient and clinician factors. Total thyroidectomy still remains a predominant procedure for low-risk cancers, which is associated with higher rates of surgical complications, worse patient-reported quality of life, and requires 100% of patients to take lifelong thyroid hormone. And thus, interventions to accelerate guideline adoptions are crucial, and so our team has developed a choice architecture intervention. Choice architecture refers to the design of decision environments, that is, how choices are presented, organized, and framed. It recognizes that small changes in how choices are presented may influence one's behavior. We believe that a choice architecture intervention can help promote guideline adoption and may nudge surgeons towards the use of lobectomy for low-risk cancers. On the front side of the intervention you see here is a checklist and algorithm that is based off the ATA and NCCN guidelines. The back side of the intervention is a treatment comparison chart comparing differences in total thyroidectomy and lobectomy's cancer outcomes, need for thyroid hormone supplementation, quality of life, side effects, and things like follow-up and cost. The aim of this study was to assess the acceptability of this intervention amongst thyroid surgeons. In this convergent triangulation mixed method study, we recruited surgeons at the 2025 American College of Surgeons annual meeting through purposive and snowball sampling. A survey collected surgeon demographics and surgeons' ratings of the intervention using the validated theoretical framework of acceptability, or TFA. We conducted semi-structured interviews concurrently through Zoom or in person, and then we utilized deductive thematic analysis based on the TFA constructs and our interview questions. And through integration of the quantitative and qualitative results, we were able to gain a deeper understanding of our intervention's acceptability. 21 surgeons participated in the survey. The average age was 47 years old, and most surgeons identified as male, white, and haven't been in practice for more than 10 years. Most surgeons were also endocrine surgery fellowship trained, worked in an academic tertiary hospital, and were high-volume surgeons or performed more than 100 thyroidectomies per year. For our TFA results, a score of 5 was most acceptable for the black bars you see here on the screen. Surgeons rated the 4 domains effective attitude, self-efficacy, perceived effectiveness, and intervention coherence as highly acceptable. We defined effective attitude as how the surgeon felt about the intervention. Self-efficacy was the surgeon's confidence in their ability to use the intervention. Perceived effectiveness was the perception that this intervention will be effective, and intervention coherence as the surgeon's understanding of how the intervention worked. A score of 1 was most acceptable for the gray bars you see on the bottom left. Surgeons rated the 3 domains burden, opportunity cost, and ethicality as highly acceptable, with burden being defined as the amount of effort required to use this intervention, opportunity cost as what things must be sacrificed in order to use it, such as time or money, and ethicality as if there were any moral or ethical consequences to using this intervention. Here we also present some exemplar convergent quotes from our semi-structured interviews. One surgeon thought the intervention was very clear, straightforward, and easy to understand. A different surgeon perceived that the intervention could be effective. By going through the algorithm and checklist with patients and not checking off any of the high-risk factors, a total thyroidectomy could potentially be avoided. A different surgeon could see how this could be a shorthand for surgeons who may not have the algorithm committed to memory. For example, lower volume surgeons that do not do thyroidectomies as often. Finally, one surgeon did not view this as burdensome as they already cover most of the content in their normal patient counseling sessions. Here we also present some divergent quotes from our semi-structured interviews. One surgeon commented that it would be a little bit more helpful if there was more space at the top so that they can draw on things. A different surgeon noted that it may not be quite effective for their practice yet, since more than half of their patients are non-English speaking. And a different surgeon cautioned that there's more nuance to individual decision-making per patient, and as long as we're clear that this document is an initial guidance and not a standard of care. Finally, one surgeon brought up that sometimes with interventions like this, you could create problems that are not there or open up a rabbit hole of questions. To conclude, our study demonstrated strong overall acceptability of this novel choice architecture intervention. The semi-structured interviews that we conducted will inform improvements to the intervention for future implementation. And we believe this intervention has the potential to accelerate the new guidelines and continue efforts to de-escalate the use of total thyroidectomies for low-risk thyroid cancers. Our next steps include assessing the acceptability with patients, expanding the language accessibility, and measuring the effect on the final surgical decision. Thank you so much. Happy to take any questions.
This paper is open for questions. While people are coming to the mic, I'll start things off. I think this is a great start here, and I noticed that your cohort that you used the study on was fairly young, mostly endocrine trained. Have you thought about expanding it to other providers who are not endocrine trained, more community physicians?
Yeah, for sure. And I think you've definitely noted one of the limitations of the study because of our sampling at the annual meeting. I think that draws a lot of more high volume or specialized surgeons. And I think it's important to involve community surgeons and surgeons who are lower volume. I will say that in the development of this intervention, we utilize the Michigan Value Collaborative, which has over 360 thyroid surgeons in Michigan. And we selected those from community programs and also from academic programs who are high volume and also low volume in the process of developing this intervention to make sure that it's acceptable for all audiences.
Thank you. And we have a
Hi, Rebecca Sippel, University of Wisconsin. That was it's a great project and a great presentation. Maybe I just missed how it was presented or how you would is this something that's integrated in the electronic health record, or is this a handout that the surgeon would use when talking to the patients? I'm just trying to figure out how this would be enacted in a clinical situation.
Yeah, thank you for your question, Dr. Sippel. So it would be a handout, and it's a front and back page, one-page handout. Ideally, the surgeon would walk through the algorithm and the checklist with the patient. And what we've noted from prior studies is that sometimes patients don't know exactly why or why not a certain surgery is for them or why they're not eligible for surgery. And so by walking through some of these high-risk factors, you can show patients that they do not need a total thyroidectomy and that you can move down to the box where you can now say you are eligible for lobectomy. And then further discuss with the patient the backside. And when we created the backside, we asked patients, what do they want to know most about their cancer surgery? I think the most important is, of course, cancer outcomes, such as recurrence and survival. But we found a lot of patients do care about quality of life, needing to take a pill every single day. And some patients even cared about cost or if they need to stay in the hospital for a day. And so by walking through the backside with the patient, we can engage them in more shared decision-making and create conversation with them so that they are fully aware of everything that might happen after their thyroid surgery.
Great. I applaud you for doing this, and I think this is absolutely something that the AES should be doing. So once you have your finalized product, we should be disseminating it, because I think ultimately that's what we as an organization can do, is provide these educational tools for our members. So thank you.
For sure. Thank you.
We have another question here.
Hi, Becky Zhang from Mass General Brigham. No disclosures. Kudos to you for doing this implementation work. It's really time consuming. Quick question about the ethicality. I was wondering if you could expand on the issues and challenges that fell into that domain. I'm less familiar with it.
Yeah, so that one, what we noted, especially through the semi-structured interviews, was because we included cost as one of the outcomes on the backside of the intervention. Some surgeons commented that they felt like patients shouldn't be making decisions based on cost alone. And after some feedback from the semi-structured interviews, we've now taken that box and kind of moved it to the very bottom of the algorithm. And it states something like, consider discussing cost and length of stay with your surgeon, but we have not included it as like a primary outcome box.
Thank you.
We have time for another question.
Scott Grant, Phoenixville, Pennsylvania. Thanks for a great presentation. I think it's very helpful to give tools to patients to help them make good decisions and kind of involve them in a shared decision-making process. My question is, the way that you sort of framed it, it seemed like it was intended to get patients to choose thyroid lobectomy, as opposed to considering the benefits versus risks of thyroid lobectomy versus total thyroidectomy. And I'm wondering if there's clinical situations where if the tool is structured in a way to lead them in one direction, it might result in the wrong choice of surgery. Like if they had a multinodular goiter, if they were already on Synthroid or something like that. And so I was wondering if you could speak to that.
Yeah, definitely, and that's definitely a concern too. In the box where it says consider lobectomy or the patient is eligible for it, there's a smaller section where it says patient may still be a candidate for total thyroidectomy in the case of like multifocality or if patient's already on thyroid hormone supplementation, and to consider things like patient preference. But the idea of the whole intervention is so that we can sort of nudge surgeons, especially those that may not perform as many surgeries per year or that default to total thyroidectomies, to really just think again about the clinical consequences that might happen for some patients if they just default to a total thyroidectomy.
Thank you.
Yeah, thank you.
Very nice, thank you.
And for our next paper, I'd like to invite Dr. Jessica Hall to the stage. It is entitled Evaluate or Ignore National Variation in the Evaluation of Adrenal Incidentalomas in Over 250,000 Patients. Authors from multiple institutions, including University of Utah, Maine Health, the Danbury Hospital, and Mass General Brigham. Thank you.
Thank you so much for the privilege of the podium. This work was partially funded by the AAS Joel Rosland Award. Adrenal incidentalomas are commonly identified on imaging obtained for unrelated illness and require both biochemical and imaging follow-up. Prior institutional studies have demonstrated low rates of appropriate evaluation. However, the existing literature is largely derived from high-volume, single-institution experiences which may not reflect national practice patterns. We therefore aim to evaluate national practice patterns, predictors, and variations in adrenal incidentaloma follow-up using a large insurance claims-based dataset. So to accomplish this, we used MarketScan, which is a national insurance claims database that captures billed diagnoses and procedures, and identified patients with adrenal masses via ICD codes. And to improve cohort specificity, we required prior abdominal imaging before adrenal mass diagnosis and excluded patients without enrollment timing information. We then assessed cases for demographic information and comorbidities, and our outcomes of interest included rates of imaging follow-up, biochemical evaluation, and subsequent adrenalectomy, which we identified via billing codes, and then performed multivariable logistic regression modeling. We identified over 260,000 patients with adrenal lesions, and the cohort had a median age of 59 and was predominantly female. 70% had private insurance, and the cohort had a high burden of comorbidity, with over 70% having hypertension and around 1/3 had a prior malignancy. We found that 53% of patients had some type of subsequent abdominal imaging within 2 years of their initial diagnosis of an adrenal mass. And to provide context, a recently published meta-analysis reported an average follow-up imaging rate of around 34%. Of note, we do not know whether subsequent imaging here reflects adrenal-directed follow-up or imaging obtained for other indications. On multivariable analysis, we found that privately insured patients were less likely to undergo subsequent imaging, whereas older patients and those with hypertension had higher odds of receiving imaging. Moving to biochemical follow-up, which more likely indicates an adrenal-specific workup, only 19% of patients underwent any biochemical testing, which is similar to the average rate found in the previously mentioned meta-analysis. Only 2% received a complete guideline concordant evaluation, and among individual tests, cortisol was the most commonly obtained, followed by renin-aldosterone testing, sex hormone testing, and then metanephrines. And these rates reflect any method of obtaining the lab value. So for example, the first bar represents all cortisol levels, including both serum and urine samples. Privately insured patients, patients with hypertension, and female patients had higher odds of undergoing biochemical evaluation, whereas older patients and those with a prior history of cancer had lower odds. And a unique aspect of this study is our ability to evaluate geographic variation nationally, which has not been well captured in prior studies. And we observed regional differences. So compared to the Northeast, patients in the North Central and Southern regions had lower odds of testing, while those in the West had higher odds. Finally, only 2% of patients underwent adrenalectomy. And while adrenalectomy rates were very low, and it's not possible to determine if this is necessarily a clinically appropriate number just based on claims data, We did find that those with private insurance and hypertension had higher odds of undergoing adrenalectomy, and women and older patients had lower odds. Some limitations of this study include a potential selection bias, as all patients were identified via ICD code, and in the real world, incidental lesions may not always be charted with an ICD. However, we would expect that patients who made it to the point of a charted ICD indicates that a provider noted that this lesion exists and would potentially have higher likelihood of follow-up. So therefore, true follow-up rates may actually be even lower than what we report here. Additionally, there's a lack of clinical detail regarding lesion characteristics and individual indications for follow-up that's inherent to claims data. But while we lose some clinical specificity, we do gain fidelity and identification of our follow-up outcomes. And finally, these findings are all observations and trends of care delivery, and the mechanisms behind these differences can't necessarily be inferred from claims data alone. So overall, we found low rates of guideline concordant evaluation with fewer than 1 in 5 patients receiving any biochemical testing. And we also observed variation in follow-up across both patient characteristics like sex and comorbidity, as well as system characteristics such as insurance type and region. And together, these findings indicate that potentially non-clinical factors are influencing whether patients receive guideline-recommended care and highlight a need for improved care delivery. And with that, I'll take any questions. Thank you so much.
Thank you. This nicely presented paper is now open for discussion.
Carolyn Seib, Stanford. Really nice job, excellent presentation, and a really great effort to look at national trends. My question is, could you look at, say, a provider ID or provider type for who was associated with the claim that's had the diagnosis code in it, and then get a sense of whether workup varied based on who put that in, whether it was primary care, endocrinology, surgery? I think that'd be really informative for us.
Yeah, thank you. That's an excellent question. And unfortunately, we were not able to link, either the order code to a specific provider or who was receiving those results. We have done this at our institution, and when we look at orders that are initiated in the emergency department, for example, we see much lower rates of follow-up than those initiated in the outpatient setting. But that's a harder thing to look at using claims data specifically, but a very good point.
Dr. Du, I think I see. Are we working on the mic? Oh, no, that's okay. It looks like it's almost fixed there. Perhaps while that's being addressed, relates a little bit to the accountability issue that we just heard from Dr. Seib's question. Like who ordered it? Who's ultimately responsible for seeing it? Why was it ordered? Whose inbox is this in? And as you think about that, what's the intervention that you propose should work here? Is this going to end up as a BPA, or is this going to end up as recommended testing on a radiology report? What do you think would work?
Yeah, so I think there are a variety of prior studies that have looked at different methods for improving follow-up. One that does seem to work is radiology reports recommending follow-up. I think that, we're in a really exciting age where we've heard a lot about AI, even at this conference, and I think that natural language processing to identify these lesions and at least either alert a provider or even kind of, move things off of the onus of a busy emergency provider or something along those lines can be helpful. I think it will require a variety of different interventions to ultimately improve follow-up, but I think that decreasing the load on individual providers and automating some of this will be helpful. Although we need to be careful about being thoughtful about what specific tests we're ordering, but I do think that is one potential avenue.
Thank you, and we'll go back to Dr. Du.
Quang Du from San Francisco, a wonderful presentation, and it's important to keep the issue of basically the underdiagnosis and treatment related to adrenal tumor. A question I have for you is related to using big database like this to answer questions. I'm making the assumption that you probably do not have size of tumor or Huntsville unit, for example, for these. And if you think about risk-adjusted workup for these patients, even some of our guidelines are not as useful because the truth is that a 5-centimeter Huntsville unit 30 lesion is very, very different than a 1-centimeter Huntsville unit 5 lesion. And so part of the thing that we have to be careful with is using database like this. So the question is that is my assumption true that you don't have that information and or even but you probably would have been able to connect it with some biochemical diagnosis in your database.
Yeah, that's an excellent point, and certainly a limitation of the database is we don't have individual characteristics of the lesions. And unfortunately, since so few patients are worked up, even fewer end up with a true diagnosis code if they are worked up and are found to have some sort of abnormality. So it's challenging to look at even kind of downstream diagnoses. And your point is very well taken that some of these might have been smaller lesions that might not necessarily reach criteria for evaluation. However, the likelihood that accounts for, nearly 60 to 70% of this cohort is unlikely. So I think we still think that this is, accurately demonstrating relatively low workup globally, but your point is very well taken that we don't have individual characteristics.
You can also assess whether or not you have underdiagnosed even the lesions themselves, because we know overall the likelihood of having a CT scan, for example, and finding of a tumor, 1% at age 30, 4% at age 60, et cetera. So you can actually double check whether or not you even underdiagnose even the findings of adrenal lesion.
That's a great point.
I think we're good.
Is there time for one more?
Yes, please.
Great study. Glad you guys are using MarketScan, which is a great database. I think there's a lot of potential. One of the problems we've run into in doing longitudinal studies in MarketScan is that you can't account for insurance churn. So if somebody loses coverage, you don't know that. And if the lack of follow-up is because they lost coverage or, they changed to a different insurance. Did you guys run into the same problem? And do you guys have any solutions for how to deal with that?
Yeah, great question.
Before you answer that, could you just please clarify name and
Sorry,
institution?
I
for the
apologize. Yeah,
transcription?
Tony Yang, Indiana.
Thanks, Tony.
Yeah, thank you for that question. So we accounted for that in two ways. One, in our multivariable analysis, we used insurance timing information. So like how long were they on their specific insurance as a modifying factor. So if patients were on that particular insurance for a shorter period of time, they contributed less to the model. And then we also performed a sensitivity analysis where we only included patients that maintained insurance for an entire year after their diagnosis and found that the rate of biochemical workup was about the same. It was 20% compared to 19%. So and in that cohort, there were 170,000 patients that maintained insurance for a year.
Great. Yeah, that's as the further you go out, the more of a problem it's going to be, so it's great that you're accounting for it. Thank you. Great study.
Thank you.
Thanks for that interesting discussion. And looks like we'll move on to the next paper.
Our next presenter is Dr. Finn, and the title of the paper is Prophylactic Central Neck Dissection Does Not Prevent Recurrence, but Increases Intensity of Surveillance, Long-Term Follow-Up of a Randomized Trial. This is multi-institutional, University of Wisconsin, Brown University, University of Chicago, University of Toronto, University of Texas Southwestern, Baylor, Wake Forest, Albany Medical Center, Mass General, and the NCI.
All right, thank you for the opportunity to present. We have no disclosures. So should we be performing prophylactic central neck dissection in patients with clinically node-negative papillary thyroid cancer? This has been extensively debated, and in this debate, advocates argue that removal of clinically occult disease from the central neck may prevent recurrence and reduce need for surveillance over the long term. On the other hand, we know that these patients have an excellent prognosis after thyroidectomy alone. They have a low risk of recurrence, and they may be spared additional surgical risks by just undergoing thyroid resection. To address this question, we previously performed a randomized controlled trial looking at prophylactic central neck dissection in patients with clinically node-negative papillary thyroid cancer. The one-year outcomes were published in 2020, and we now report long-term follow-up from this cohort. The goals of our study were to compare the differences in structural recurrence between patients who underwent total thyroidectomy with prophylactic central neck dissection or total thyroidectomy alone. We also aim to compare the intensity of postoperative surveillance between arms, given that a common argument for performing prophylactic central neck dissection is to simplify postoperative surveillance by removing the central neck contents. So we included patients who had papillary thyroid cancer without evidence of local or distant metastasis, and these patients were enrolled between June of 2014 and August of 2019. Patients were randomized at the time of surgery to either total thyroidectomy alone or total thyroidectomy with an ipsilateral central neck dissection if intraoperative assessment of the central neck contents showed no evidence of gross nodal disease. After the first study year, patients were managed according to local practice patterns without any specific input from the study protocol. And to perform long-term follow-up of this cohort, we revised or reviewed each patient's medical records until their last recorded appointment with either endocrinology or endocrine surgery. The total thyroidectomy group included 29 patients who were followed for a median of 7.6 years, and the total thyroidectomy with prophylactic central neck dissection group included 28 patients who were followed for a median of 6.2 years, and these patients were analyzed using Bayesian negative binomial regression. Our primary outcome was recurrence, which we defined as re-intervention for any recurrent papillary thyroid cancer. We included any reoperation, ablation, or additional radioactive iodine during the follow-up period. And then to assess intensity of surveillance, we looked at the cumulative frequency of clinic visits, imaging studies, and biopsies during follow-up. Our cohort had a median age of around 47 years. They were majority female and had small tumors with a mean tumor size of 2.2 centimeters. Among the patients with total thyroidectomy, about 10% of patients ended up having a positive lymph node in their specimen despite not undergoing a formal neck dissection. And among the patients who did undergo a neck dissection, 28.6% of these patients had positive nodes in their pathologic specimen. So over long term, we did not observe any recurrences requiring reoperation or reintervention in either group. This made it impossible to directly compare the groups. However, we did also look at the ATA response to therapy at the patient's last visits with endocrinology or endocrine surgery, and we saw that the majority of patients in both groups had an excellent response to therapy, and there were no differences in response to therapy between the groups. So then we looked at kind of the absolute and relative differences in intensity of surveillance over the follow-up period. And we saw that in clinic visits and ultrasounds, there were no differences between the groups and how often these patients were being followed. And looking at total surveillance events, we saw that patients who underwent a total thyroidectomy had a median of about 2.1 surveillance events per year, and patients who underwent a prophylactic central neck dissection had about 2.4 surveillance events per year, and there were no differences between groups in these absolute numbers. We also looked at the relative intensity of surveillance. This represents an incident rate ratio with adjustment for duration of follow-up and added control for age and pathologic features. And we actually saw a slight increase in intensity of surveillance among patients who underwent a prophylactic central neck dissection. However, we recognize that this confidence interval is wide and does extend pretty close to zero. So to conclude, we found that structural recurrence is rare regardless of whether or not patients underwent a prophylactic central neck dissection. And so we think that any absolute reduction in risk of recurrence from prophylactic central neck dissection is likely to be small and of uncertain clinical significance, but we can't exclude a modest benefit with this data. And we found no evidence that prophylactic central neck dissection decreases the intensity of surveillance over time. So we conclude that this long-term data adds to our growing body of evidence that make it difficult to support routine use of central neck dissection for patients with clinically node-negative papillary thyroid cancer. And these findings are concurrent with the most recent ATA guidelines. So thank you.
It's very well done. Paper is open for questions. I think Dr. Shah made it first to the mic.
Okay. Shah, New York. Thank you very much for giving us this follow-up. And I would like to congratulate your group for doing the first and the only randomized study on thyroid cancer in United States. That deserves a lot of credit. And also happy to see that there is no recurrence in the group of patients who had prophylactic central neck dissection, which corroborates with our current philosophy and the guidelines by ATA. Just historically, this was a very casual statement in first ATA guidelines in 2006, that prophylactic central compartment dissection should be considered for patients with papillary carcinoma more than 1 centimeter. It was very casual. I don't think there was any good data on that. In 2009, within 3 years, they changed the guidelines. Do it only in aggressive tumors, larger tumors, or gross extracellular extension. And since then, we have been debating about this, so your information is very interesting. The one question I have is, you have talked quite a bit about intensity of follow-up, but it looks to me very marginal. And probably the follow-up depends upon the physician, the availability of the physician, where does the patient come from, how much concern the patient has, and without that information to make a judgment that we are following these patients more intensely, those who have neck dissection, may be little erroneous.
Yeah, thank you for this comment. So, yeah, our main conclusion is that we didn't see a decrease in intensity of surveillance, which is an argument that we've heard for prophylactic central neck dissection. And we totally agree that we think the intensity of surveillance more likely is related to the patient's response to therapy at their last visit. How the patient is doing when you see them in the clinic determines when you want to see the patient next in the clinic. We also think that taking out the central neck nodes provides more information that may make people unnecessarily worried, even though this is still low-risk disease, and that maybe more information is not always better in this situation.
Chris McHenry from Cleveland, Ohio. I enjoyed your presentation, and I think like to emphasize exactly what Dr. Shah has said, that it's important to recognize that your study is prospective, it's randomized, it's controlled, and although your numbers, overall numbers comparatively are relatively small, you really demonstrate no difference in long-term rates of recurrence. And I think that's hugely important to recognize, because it really demonstrates that there's really no oncologic benefit for patients with papillary thyroid cancer and clinically node-negative disease. And I think that's just really important to emphasize. And I think it's also going to be important to examine this in the group of patients that have tumors that are between 2 and 4 centimeters, larger tumors, to really determine is it a benefit in that group. I just wanted to ask you one question, and it may have been presented early on in your previous study, but I think it's important too to recognize in the patients that get prophylactic central neck dissection that their rates of complications may be higher, and in particular hypoparathyroidism. So I wondered, can you give us any information of the complications in your groups, particularly hypoparathyroidism and maybe also recurrent laryngeal nerve injury?
Yeah, thank you for this question. So we looked at this in the original trial with 1-year outcomes, and we didn't re-examine this data because we didn't expect the complications rate to change after a year. In the original study, we didn't see a difference between groups in rates of complications, but we recognize that this is a smaller study done by a high-volume group of surgeons. And so on larger studies, there have been evidence that prophylactic central neck dissection does increase rates of complications.
We have time for one more question.
Peter Angelo, Chicago. Thanks. Great presentation again. Congratulations on doing a prospective study. My question's a simple one, which is when people say I've done a central neck dissection and bill for it, it doesn't always result in lymph nodes being removed. And so the intent to do a central node dissection is often different. And so I wondered, what was the mean number of lymph nodes removed in those patients who actually had, who were in that arm that got a prophylactic central neck dissection?
Yeah, so they had about 6 lymph nodes removed, I think. I don't have the data on this page.
And I would also say it would be interesting to know whether the range was from 0 to something or more than 0.
I don't remember the exact number of lymph nodes removed, but I'll check on that. And
Thank you.
It'll be in the manuscript. Thanks.
Thank you for sharing this updated information.
I'd like to thank all the presenters for excellent presentations and staying on time.